Query to Dr. Stephen Gatter. What was the incidence of thromboembolic episodes with these cases with factor 7A?
Very good. You'd think that there would be a high incidence of thromboembolic phenomenon in these people. Remember that we collected data up to 28 days from the time we gave the factor 7A. So overall, the number of thromboembolic phenomena was actually quite large, except that almost all of them occurred 3 and 4 weeks later, so they could never be connected very much with the administration. All I can say is that in the obstetric population, there wasn't a single one where you could say, look, next day they had a thromboembolic phenomenon and it's quite likely to be connected. So almost all thromboembolic phenomena were in patients who were in intensive care for a very long time, had plenty of reasons for getting thromboembolism, and I can't see that was in any way associated with, that's not a single one. In the rest of the groups, again, in the cardiac patients, it's difficult to determine what caused the chicken. Most of them had been on pump before that. In the cardiac patients, many of them have been reversed with protamine after having heparin. So again, it's a bit difficult. But nevertheless, I think that this is not even a risk at all of this agent. The other thing I wanted to add is that I really liked what you said about tranexamic acid, because this is now, after 7A, 10 years of 7A is the next flavor coming up. And I don't know what it's called over here, but we buy it as cyclocapron. And cyclocapron is interesting, used in combination with factor 7A. And so one of the things that I gave this lady 2 weeks ago was exactly that, a factor 7A, and because the bleeding was still going on, I thought, well, perhaps we'll use tranexamic acid. And really they're quite complementary to each other, because one stops the fibrinolysis, and one produces a stable fibrin clot. So basically, it might be not such a bad idea to combine the two agents together. The combination I don't know, though. I don't know what the combination will cause in thromboembolic phenomena, but I would say that probably the risk is quite small as well. You know, I'm always surprised. In a way, it's a joy doing obstetric anesthesia, for those of you especially who are novices at the game. Because these people, in spite of having 212 units of blood products, and in spite of being ventilated overnight for what I thought might be some pulmonary edema, perhaps a bit of ARDS, perhaps a bit of SIRS, by next morning at 5 o'clock, this happened, as all these things happen in the evenings, don't forget. They never happen during ordinary hours. It's called Murphy's Law. You know, Murphy's Law says that everything happens when it's not supposed to happen. And sure enough, almost every bleed starts at 7 o'clock in the evening, goes till midnight. On the weekend, and usually on public holidays too, Diwali, all those sort of things. So the answer is, you know, with these patients, suggestion would be a good idea to use tranexamic acid with factor 7A, thromboembolic phenomena, not much, and in terms of outcomes, obstetrics, especially if you use these things early, especially if you get very aggressive, I think with dealing with hemorrhage, I think you'll find that they bounce back so nicely. I mean, this woman at 5 o'clock the next morning, 4 hours or 5 hours after we'd finished doing this, was sitting up in bed, wanting to have the tube taken out, and as soon as she woke up, she said, "Where's the baby? I want to breastfeed." And she was breastfeeding the baby. If you'd gone back 24 hours later, you'd have thought nothing much has happened. So that's the beauty of starting with very good protoplasm in the first place. They bounce back very, very well.
Dr. Stephen, could I just add that when you're faced with a desperate measure, I think the answer also is quite desperate. So I think, would it be justifiable for us to risk the chance of a thromboembolism when you're really in a tight situation? You're allowed to use a combination of factor 7A as well as tranexamic acid. And, as you said, you might have a problem with the thromboembolic phenomenon, but it's a risk worth taking.
It's not even a risk, I think. You know, I think that there is no risk in these patients of even in using the combination. I think it's more theoretical than real. You know, that really, I think, as I said, these people not only bounce back well, but thromboembolism has not been a problem with any of them. You know, I think, stabilizing a clot, for example, especially if it's only going to be at the place where the problem is in the first place, we're seeing a brand new problem, of course, in Australia. There's so much concern about thromboembolism, and generated mostly by the English experience. I don't know if you're all aware of what's happened in England over the last 5 years. But in the UK, if you have somebody who comes into hospital, regardless of which group of patients they are, they haven't been covered by thromboprophylaxis. There's something in the UK, in London, called the Centre for Thromboembolic Disease, or something of that sort. And they have gone to Parliament to pass legislation, right, that all patients are entitled to food and water and also thromboprophylaxis. You know, it's like, you know, so that nowadays, and the Parliament passed an incredible act too, which says that the trusts, as they know in England, which are the bodies that run the health service effectively, are personally responsible for all the costs generated by the patient as a consequence of a DVT, a pulmonary embolus, and so on, for the rest of their lives. The trusts, not the Department of Health, right? For the rest of their lives, for the consequence, if you haven't done something to try and stop them getting it. So basically, if they were high risk, you did nothing, and they got a thromboembolism, and they got a DVT, and ended up with edema, for example, in the legs for the rest of their lives, or developed pulmonary embolism with pulmonary insufficiency, all that respiratory therapy, all that lymphedema treatment, blah, 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 was suddenly the cost of the trust. And if they went to court, right, with a case of damage caused, again, it would be the responsibility of the trust. So one of the things that you see in England is all these nurses walking around with clipboards, and as soon as somebody comes in, they want to know, you know, do you smoke, are you female, blah, 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 blah. And as soon as you go into the moderate group, in the middle, then they get fitted with DVT stockings, they get calf compressors in theatres, blah, 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 blah. And once they are high risk, because they also smoke and do other nasty things to themselves, then they end up with on heparin. So we're seeing a lot of obstetric patients, for example, who at the end of the surgery, at the end of the cesarean sections, have heparin on the night of the surgery. In Australia, it hasn't quite got to that yet, but we certainly are seeing a lot more people on not just on heparin now, but on clopidogrel and fondaparinux and some really nasty other agents, which can cause quite significant bleeding. I think that the end result of all of this is that we might find in 5 to 10 years' time that the risks of thromboembolism have been replaced by the risks of bleeding, and that there's no great advantage overall. But in the meantime, in the interim, from an anaesthetist point of view, we really need to start to make some decisions as to how we're going to treat people who are on these agents. So I think it's an interesting phenomenon. One thing to remember there, I think probably one of the best things that's happened to Australia in the last 2 years, is that we give all our anticoagulants, regardless of what they are, in the evening. Not in the morning like everybody else, but all of Australia and all of New Zealand gives all its anticoagulants in the evening. Why? Because what happens in hospitals, everybody comes in at 8 o'clock, does the ward round, and the intensive guy wants to pull out the chest drain, the anaesthetist wants to pull out the epidural. So basically you're getting it at trough level rather than having it at peak activity of the anticoagulant. So a very useful and very simple, it costs nothing, it's a very good thing. But if you look at all Australian protocols, it's always either 8 p.m. or 10 p.m. depending on what the practices are for the hospitals, for heparins, for low molecular weight heparins, and for all the other nasties, warfarin and so on. Okay?
All of us are not fortunate enough in a place like where Dr. Ghat is. Most of us work in peripheries. You are in a district level hospital. The patient comes with obstetric hemorrhage. You yet do not know whether it is major or it is intermediate or mild. You have to take up the case. Next case, if I have to send it to Dr. Ram Kumar, he is about 200 kilometers away. How do I proceed, sir? Most of us are not fortunate to have 200 units with us. We are working at a district hospital. The tertiary care center, like Dr. Ram Kumar, is 200 kilometers away from us. The road will take 6 to 8 hours. The patient has come to us bleeding, especially you cannot say no at a government hospital. Dilemma to the anesthetist, our palpitation increased. I don't know yet whether it is a major obstetric hemorrhage or it is intermediate. How should I proceed? The blood bank which we have will have only 2 units or 3 units of each blood group ready. This is the real scenario. How do we go about?
Let me say something before you have your little to say. In a way, it's very sad that you asked me to talk about Factor 7A, because I think Factor 7A has saved less lives than the very simple things that we've done at the same time. The first is the massive transfusion protocol. I'm really happy that you mentioned, the massive transfusion protocol. It costs nothing, right? All it is an agreement between you and your hematologist or your blood bank that they will provide blood in a certain sequence if it's fractionated. In your case, you're even luckier. You don't actually have fractionated blood. You have whole blood. About the best thing you can possibly get when you're having a massive blood loss is whole blood. After all, if you look at the massive transfusion protocol, it's 1:1:1. So basically you spend thousands of dollars splitting it into different pieces, and then when you have a massive blood loss, you put them all back together again. That's what it's all about, really, if you think about it. So in your case, you're better off. Also, it's the pre-preparation that goes into hospitals that is also very simple. For example, at the workshops, we talked a lot about trolleys, right? You can have a massive transfusion trolley where you put all the bits and pieces that you need. You don't need cell savers in most situations. You don't need all this exotic equipment. You don't need rapid infusers. If you know, a pressure bag on a blood bottle costs $4, right? At 1,600 rupees, right? It's nothing, right? You can improvise with a lot of these things, provided that at the time you have them. And that costs nothing. Factor 7A really is down there with the small stuff. It's with the rapid infusers and the cell savers and all the other things that you get. But if you go home and you go to your blood bank and said, look, you know, if we have one of these, how will we go about it? And you set up your own massive transfusion protocol, but ask them to provide you with blood in some fashion, and tell them that when I ring you up, I'll only want to tell you 3 words. Massive transfusion protocol now. Mrs. Brown, number 4516. That's all you need to do to activate the massive transfusion protocol. It costs absolutely nothing. And indeed, at one of the lectures I gave earlier on, I showed that the targets for our hospital for blood usage have actually gone down every year since we started the massive transfusion protocol, because people are using it more sensibly. We're not wasting, as used to happen before, the things that are expensive, the fresh frozen and the cryo, because now we know when we're going to get them. We don't give the factor 7A too late, because it comes with MTP pack 2, which means they've had 4 units of blood, and then 4 units of blood, and then at somewhere around the 10 to 12 mark, you've got your first 7A sitting in your hands. It's part of the transfusion protocol. You don't have to ask anybody. It arrives at the right time, right? And that way you're not wasting it, right? So what I'm saying is that the simple things in this game are much more important than the expensive things, okay? And even tranexamic acid, that's the small print. Concentrate on the big stuff. The big stuff is getting organized. And the other thing that's been very useful is hemorrhage drills. We've now done it for 8 years in Indonesia. In Indonesia, there's a requirement from the government that all doctors have to go to Jakarta once every 3 years and go for a whole week of anesthesia retraining. But it applies to everybody, the surgeons, the hematology oncologists, the hematologists, everybody. And the government actually pays them to go to Jakarta, provides them with a room for a week and that sort of nonsense. But all we teach them on those things every single year is exactly how to get organized with these things, with the hemorrhage box, the hemorrhage drills. The hemorrhage drills are now basically, you know, everybody talks of simulators and how, you know, I don't know what it costs over here, but in our place, it costs $550,000 to buy a high fidelity simulator. You can do exactly the same, right, with a few little props. For example, we use theater pants, right? A set of pants, ordinary pants that you use in theaters, a second one with a hole down here, a bit of red cloth from your saris, stuff it up between the 2 pairs of trousers, and to simulate bleeding, we just pull the red cloth out. That's the only prop we have. That and some pads that we put on the floor with which we use, you know, the blood that they use in film. You know, that sort of nonsense. You make it with paste and so on. That's the only props you require to simulate a massive hemorrhage. But if everybody knows what to do, and I'm not talking about doctors now, I'm talking about all your nurses and all your porters, and they know where to go to get blood, and you do it in real time, every day. We do this once every 4 months. Admittedly, it's 1 month might be, every 4 months might be preeclampsia, somebody having a fit, or somebody having a massive bleed, and then the next time it's shoulder dystocia, those sort of things. But if you do them regularly, I think it'll save you far more lives than buying yourself some factor 7A. Sorry, but
And that's okay. I think you've done. But Doctor here wanted me to respond as well. And we have been through a situation where we started off with the blood bank giving us only whole blood. Then that time we were wondering why we're not getting blood components. And now I think whole blood has made a resurgence. The wheel has gone around. And our experience with trauma and war injuries has shown that whole blood is definitely has come back, has made a comeback. The only problem now is most of our blood banks are only geared to giving us blood products, and the transfusion rules have also become such that they don't store whole blood anymore. And I think in your case you said you will have 2 or 3 units of whole blood. Unfortunately, that may not be fresh enough. That's the problem, and the coagulation factors will be very low. So if you can get fresh blood, whole blood, that is still fine. I think you can still give fresh whole blood, which is.
Fresh.
Yeah, that's the problem. So I think in that kind of a situation, maybe the big plus point that you might have is you might have a very good obstetrician who might be able to salvage the situation, right? So in a setup where these kind of things happen, you don't have other support facilities. Usually the obstetricians are very good in this area, so you might actually save the day because your obstetrician is used to dealing with these situations. But I think whole blood, if you can get fresh whole blood, I think that should be the answer. Like Geeta was saying, if you can organize enough donors quick enough, I think that might be the answer. You don't have to go for blood component therapy.
So how different is that, sir? Transfusing, for example, massive transfusion protocol.
Yeah.
If you use only whole blood, so how different it is going to be? Like it's only 1:1:1.
It will be volume. No, as much volume as you expect has been lost. Yeah, same. If your estimated loss is, sorry, you want to say, Anju?
It hasn't to be a stored blood. It has to be a fresh whole blood. But it will supplement the same amount.
Same amount. And one more question, sir. What about this tranexamic acid? If there are expected obstetric hemorrhages like placenta previa, accreta, can we give it prophylactically, preoperative?
No. It's usually, when you've tried everything else.
That's what the drug. Some literatures are telling
yes,
that.
But I don't think we should use it prophylactically.
Yeah, there are some centers where prophylactically they've been using tranexamic acid.
No, but remember, in obstetrics, we're dealing with the baby who is now delivered in most situations, luckily, right? And most of these agents should not be used with the baby on board, right? The placenta acts as a huge source of tissue thromboplastin. So even with factor 7A, basically almost all of them are after delivery of the baby. Right. In the meantime, they use the usual things that you normally use, uterotonics. In the uterotonics department too, I don't know if Bill came in. Is Bill still here? Bill, have you mentioned carbetocin at all? One of the things that's happened in the last 6 months in Australia, and it's funny because it's actually come to us from some place like Egypt, I think. They're making an agent called carbetocin, which is synthetic oxytocin, but much longer acting. It was made initially for Kenya and countries like that, where blood is not available at all, period. If you're on top of Mount Kilimanjaro, you don't expect to get too much blood. Secondly, it's also a common occurrence for people to die for lack not of a massive blood transfusion, but for 1 or 2 units. I mean, these guys have a hemoglobin of 6 before they go into labor, often. Right? So they lose a little bit, and they die anyway. So in those situations, having a long-acting agent that contracts the uterus for about 10 hours and not having a tonic uterus for 10 hours. So you use it almost the same as you use Syntocinon, either a small bolus and then a short infusion, and that will give you 8 hours of uterine contraction. So I think it's going to, and it's also cost-wise, it's the same price virtually as Syntocinon. So carbetocin is one thing worth keeping in mind, and for those of you who are in positions of power and might, perhaps you can push the government into getting in carbetocin, because it really is quite useful. I use them for routine cesarean sections. I use them both simultaneously, because then it saves me having to put up an infusion for 12 hours of Syntocinon now. So I usually give Syntocinon stat, carbetocin as a short infusion, and that's it, off we go. And then you can pull out the drip if you want to, especially if you've done single shot spinals for your Caesar.
I don't know how long it takes to make factor 7A available. Do we need to, when we expect like a placenta previa or something, do we need to keep, communicate with the providers and, keep it ready in our setup? Like, it's not there available ready in any hospital here, I don't think. We need to speak to the company people and stuff like that. And the other question is, say for a placenta percreta, after the baby is out, why don't we give tranexamic acid? Is there anything against that?
Before the baby's out?
After.
After, there's no problem.
Yeah.
Before is the problem.
After, but before the major hemorrhage starts. Yeah, yeah.
Well, this is what's happened in cardiac, really. If you think about it, the cardiac surgeons have all decided that sometimes they will use even factor 7A prophylactically, virtually. It's an expensive drug. I mean, you decide for yourself what's most expensive in your hospital, whether it's giving a dose of factor 7A on the off chance that it's one in every 10 cases, it is going to stop somebody going back to theatres. That's what it's all about. And to say that I've got this gut feeling that it's going to work on this patient, again, is not truly scientific evidence. But let me tell you something about factor 7A that's kind of interesting. In Israel, which is where factor 7A started its life, there used to be a practice that as soon as there was a bomb in a marketplace and there were 30 people with massive trauma, they used to send out the motorcycles with O-negative blood, right? Nowadays, they send out the motorcycles anyway with ampoules of 7A. They give them a shot of factor 7A for all the injured people and get them to hospital. So basically all they're doing is buying a bit of time to get them to hospital, you see. But it solves the problem of having bottles of blood being shifted around, having large amounts of blood just sitting around for the next bomb explosion, all that sort of thing. So really, in your case, I think the solution might well be to have like a state arrangement perhaps, or even, groups of hospitals having a small supply. After all, you're not going to get a massive hemorrhage every day. Having a small supply and truly use it in a responsible fashion, like making a half a dozen hematologists, for example, responsible for the release of factor 7A. I think that really is the solution somehow.
I was thinking of the time scale, like you've got a major hemorrhage.
Well, as the gentleman said earlier, not major hemorrhages don't become major hemorrhages until they become major hemorrhages. Initially they start bleeding slowly. It's very rare that you can't do something temporizing, like uterotonics, for example. It's just the ones that worry you the most are the ones that go for 12 hours, where the bleeding is continuous and you keep replacing stuff. We always have time to give them volume, for example, initially. We can always temporize with a bit of colloid. We can always temporize with whatever we have, O-negative blood. That's the other thing I want to tell you, by the way. We've given up using O-negative blood entirely across Australia. Admittedly, we do have blood banking facilities in most hospitals, but getting group-specific blood is usually much easier. And it's very cheap to do a group and screen. So basically, we know what the patients are going to be. All cesarean sections get a group and screen. But the blood bank then guarantees that within 4 minutes of us telling them that we need blood, they will be able to give us group-specific saline cross-match. Not a full cross-match, right? But the screen is useful because they know exactly which ones they might have difficulty getting blood supplies of. Remember that the safety of saline cross-match, right, is 99.9, and then there's 7 more nines, times 9 safety. The funny blood groups, the Kells and the Rigby's and all that sort of nonsense, is a very rare occurrence, and it doesn't apply to obstetric patients either. It applies mostly to bone marrow transplant patients, for example, who get transfusions all the time and develop antibodies. So those antibody groups are not very important for us at all in obstetrics. If they can guarantee us blood in 4 minutes and it's group specific, it's actually safer than O-negative. You see? And you don't have to waste O-negative blood. Because after all, O-negative blood in the past used to be the ones that everybody wanted. So all O-negative blood was pooled away from the O-negative patients. You see? All right.